Boridar Power Croeso Cavalbo the board Yakib. Can I ask people to ensure their mics are turned off because I can hear some background noise. Today's meeting is being live streamed as usual, and there is a translation facility available, and I would encourage members of the board to use the language of their choice, please. I will move straight to the agenda. The first item is welcome and apologies. Welcome from me to those who are joining us by live stream and also those on the board. I have apologies from Linda Thomas, who has another commitment, and also Adrian Thomas, who's absent from work at the moment. I will move us straight into the patient and staff story, which is with you, Jill, I believe.
Sorry, Mark, it has moved towards Tagana, but Matthew, I think, is online to take us through it.
Thank you, Mr. Chair. Thank you, Jill. Could I just ask the host to please enable the screen sharing function so that I can play the story? Just while I'm bringing that up on the screen for colleagues, I'd like to thank the patient who we're referring to as Mrs. W here, who's kindly shared her patient story with her. I'll now play the story for you, and then again, I'll just summarise the learning and the actions.
I was told that I needed to have a removal of BCC from my face. Because of COVID, I wasn't able to come in and have a proper conversation with the MaxFax surgeon, but I did have a phone call, and I was very grateful for that. The consultant was very kind. She did explain quite a lot, but it left me even more worried, I guess, about how my face would look after the surgery, because she talked about maybe a skin graft, maybe a skin flap. Now, the other thing is, I am a nurse, I'm an experienced nurse, but even for me, with the experience that I've got, I was still very, very frightened. I didn't sleep that night, and so the following day, I decided that I'd need to have more information before I could have it done. I did phone MaxFax department, and I had a nice conversation with one of the admin staff, who very kindly said that the doctor I'd spoken to was doing a clinic and she would see if she could phone me, and she did. Right away I was able to have another conversation with her, and she answered more of my questions, but I was still left feeling very, very scared. I asked if there was any information at that stage, and I was told that no, it would be okay, and that the next time I had any conversation with her would be when I came in to have the surgery done. I asked if it would be her, and she said yes, it would. So I came in to have the surgery, and it wasn't that particular consultant that I'd spoken to. She was operating next door. So that really made me feel very, very uneasy, because I had been told it would be her. But I did see a very, very nice lady. She was fantastic, and I couldn't fault the medical care that I got that particular day. She spent a great deal of time explaining what she was going to do, or might have to do, once they'd anaesthetised my face, until she was actually cutting the lesion out. She didn't really know whether the edges would come together without a graft, but she was reassuring. Nevertheless, I was terrified, absolutely terrified. She then said that the worst part of the procedure would be the injections in my face, the local anaesthetic, and you know what? I was not prepared for that. It was extremely painful. After the surgery, she was able to tell me that, or during the surgery, she was able to tell me that there would not be a need for a skin flap, and that she was able to bring edges together. So that means it would be a straight scar, and I was relieved for that. And then she finished, and then it was time for me to go, and I was handed half of an A4 piece of paper with some numbers on and some gauze in case my face bled overnight, because she did say that she'd had to go a little deep so it might bleed. So I left with the gauze and this A4 piece of paper. I was totally traumatized by that experience. I asked there and then if there was any written information that I could take away with me, and the answer was no. We have this is it, you've got the numbers here, just call us. To be told that there was no written information for an excision of a facial lesion was difficult. I went home and rested that day, but I was just so scared. The following 2 days later, when I was able to take the gauze off to see the extent of the scar, it was big. It was on this side. It was big, and I was very frightened. So I started then doing my own research, and I found lots and lots and lots of hospitals where there was proper patient information on excision of facial lesion, and I was able to download lots of it, and I held on to this information because for me it was a comfort to know that actually the end result would probably reduce, if I looked after the scar, probably be less scarring. However, I had to take the dressing off 2 days later, and within 3 or 4 days it was obvious that there was some infection in the scar. I phoned here and I did get to see a nurse. I don't know whether she was a nurse practitioner, but she certainly was a registered nurse. I didn't see a doctor. So I did come in, and I brought with me the patient information that I had downloaded. Only one of them, but I had downloaded six or seven actually. And I brought the information and said to the staff nurse, you might find this really helpful, because I found the whole experience very shocking, really. To say she was dismissive is an understatement, and I'm still very cross that a registered nurse, as I indeed am, should speak in such a derogatory way about 95%, and I quote, I've written it down, 95% of patients would not understand this information, and neither would they read it in the first place. I was so shocked. So I said, well, I would be one of the 5% that would have read it and would have benefited from this, so could you please consider it? But it was just dismissed, and I went away thinking, I have to do something about this. Fortunately, I followed the information on the patient information. I followed all the information and used a silicone gel, and you can hardly see the scar now. So, I'm really, very, very satisfied with the scar. But I would just love, as an outcome from this, to be able to help other patients, really, and hopefully the Max Fax department could maybe have a look at the information that's come from other hospitals and maybe develop something for here if there isn't anything available.
Matt, before we come to discussing the learning and the responses there too, that was a very brave thing for that patient to do. Can you ensure that there is a letter that follows from Jo and I to thank her for giving up her time?
Of course, Mr. Chairman, absolutely, now, so we can make sure that's done.
Joining us personally by video. Thank you.
Of course, yeah,
Okay.
I'll make sure. So I think just by way of a short update, the boards will have seen the accompanying paper that describes some of the learning that's taken place. Firstly, the learning from this has been shared back with the service and the staff involved, and there's been reflection of this story across the MaxFax department. The service have taken a number of actions. They've been very proactive in responding to this. So the current patient information leaflets in the MaxFax department have all been reviewed. They've all been through the patient information and patient readers panel. They have undertaken a review to see what best practice is out there across other hospital services and how that can improve the quality of their own leaflets. A junior doctor has recently undertaken some work to look at the satisfaction of post-operative information as part of the audit process, and the patient experience team have been working with the service to look at, again, their patient information and how that's communicated. On a wider scale, patient information leaflets was something that my team took on a coordinating lead role about a year ago, and we've been undertaking work to establish a patient readers panel that has patient carers as well as subject specialists like Welsh language equality and other colleagues to review the quality of leaflets before they're finalised. We're currently working on a library on the new intranet site, BetsyNet, of all patient information leaflets. There's work underway, and this is a long-term piece of work to look at all of the existing leaflets and to bring those through that process so we can ensure the quality is improved across the health board. And we've had conversations with our colleagues and partners in the communications team about how we can strengthen the templates and formatting and other kinds of information as well. So there's been some local learning, and equally there's been some wider improvements over the last 12 months as well. Thank you, Mr. Chairman. Happy to take any questions.
Gaynor, I saw you flash up on my screen. Is there anything you wish to add? You're on mute, Gaynor.
I say I apologise for being slightly late, but it kept throwing me off the Zoom. Yes, it was very brave of this lady to do the story, and we need to learn from it as we are. But not only the points about the information leaflets, but also about the attitudes and the way in which you're spoken to by staff. So we are making sure that we build that into our cultural work and the work that we're doing with the nurse leaders.
Thank you. Nick.
Thank you, Chair. I'd echo the points Gaynor has raised, but I think we also need to consider what patient information leaflets and information is given in support of the consent process. So that is just a routine issue. And whilst clearly there may be issues around individuals, this is a whole multidisciplinary team support. And I think there's some learning there for us as a health board about what our routine information giving is to support patients, not just in this service, but in any service. So I'll make sure that we take that forward, not least as part of our consent and note-keeping work. Thanks, Chair.
Thanks, Nick. Any observations for anyone else in the meeting? John.
Yes, just a very brief one on this one with regard to patient information. The COVID vaccine information clearly was something that everybody needed to follow, and yet the information that was provided, because it was manufacturer information, was in fact incorrect, and we issued thousands and thousands of leaflets because it referred there to people having 2 vaccines when this was at the first stage, and that your second vaccine would be within 3 weeks. So again, I think we need to be careful around information which is generated within BCU for patient information, and perhaps sometimes reviewing information when it comes from a third party, such as a clinical supplier of some kind. Thanks.
Thanks, John. Any other observations? Claire.
Don't Mark. It was just a question really about whether or not there's any early feedback from the 3-week surveys that have been undertaken with patients who've recently undergone procedures, whether we know now, you know, whether we've had good feedback or different. So is there any early information that could just be referred to that gives us more assurance or reassurance?
Matt?
Yeah, so the feedback from that survey is relatively positive. I think the only caveat I suppose I want to put, Claire, is we probably didn't have any sort of the improvement work to measure the improvement against, but the feedback, certainly now some of those changes have been made, has been positive.
Thank you.
Jill?
Thank you, Chair. It's following up on Claire's point to ensure that if we are using this as a bit of a baseline, that we do follow it through. That's the first point. And the second point is a bit of a question. The individual who was brave enough to tell her story, have they been involved in the pulling together of that information? Are they comfortable with it?
Yes, Jill, that's right. So this lady contacted our chief executive, and as a result of that intervention, the improvement work commenced, and we have involved this lady in that process.
Thanks, both. We have previously discussed and agreed ensuring that there is follow-up on patient stories to ensure that the lessons learned have been embedded. Indeed, that is reflected in the action table previously agreed by this committee. You have provided an update, Matt, I see, to that action. I don't want to jump to the action table at the moment, but are you content that there is a process in place that can provide assurance to you and the board that that embedding of learning has occurred as we move forward?
Yes, there is. So patient experience team follow up on all of the actions from all of the stories that are presented here to the board and also to the QSE committee, where we also present stories. In this case, we have the evidence of the new leaflets. We've got the evidence of those being used and implemented. We've got the evidence of the involvement of people in the process of developing it. So yes, I feel we certainly have the evidence to offer that assurance. And there is an item on the QSE cycle of business to bring an annual report on patient stories, where we can update on the progress of stories that have been received over the previous 12 months.
Thanks, Matt. Okay, I'm going to move us on then, if I may. So we'll move to item in point pimp, which is the draft minutes of the health board meetings. Actually, before I get there, declarations of interest. Are there any declarations of interest from any member of the board in terms of the items on the agenda today, please? No. Okay. All right. Thank you. I will then come back and move us to the minutes. So the first set of minutes are for the meeting on the 10th of March. Are colleagues happy with the accuracy of the public meeting minutes for the 10th of March?
Yes.
Okay. And I've got yes from John and Jackie. Thank you. Then in terms of the public meeting minutes for the 30th of March, are colleagues content with the accuracy of those minutes? Yep. Okay. Thank you. I've got signals of support on the accuracy. So
Mark, apologies. I've raised my hand. I was trying to raise my hand, not give you a thumbs up.
Oh, okay. Okay.
In terms of the first set of minutes, if we could use trade union in the brackets, if we're going to use the brackets as opposed to staff side, please.
Okay. Philippa, can we pick that up, please?
Of course.
And John, I now think you want to come in as well. Apologies. John C.
Thanks, Mark. Yes, I was putting my hand up, Rodney. Thumbs up. There's a small correction for me on page 10, 2268.3. It reads as if the congratulation is for the people involved in the evaluation rather than the conclusions of the evaluation in terms of the people involved in the project.
Okay, thanks, John. So can we correct that too, Philippa, please?
Yeah, no problem.
Thank you. Right, I'll move us now to the action log then, which has been circulated. Please feel free to stop me as I take a run through of this action log. The first is shown at 1, and this concerns the new format and content in terms of the report, the operational plan monitoring progress report. There have been a variety of exchanges, particularly between Joe and I, and that is due to return to the board in July. So we'll leave that open. The next in terms of vascular was to review the decision process. There has also been some work done by the Good Governance Institute in that regard. We agreed, as Nick has put, to leave this action open until the final review is received. Nick, is there anything else you want to say in terms of the timeline of early June and what we're likely to see?
No, I think we have the draft report available from the internal review, Mark, and I think we will be able to take that forward within the next 2 or 3 weeks.
We haven't shared that yet, Nick, though, have we?
No, it's still in draft, Mark.
Okay, so when do you think it'll be ready to share? Next few weeks?
Within 2 to 3 weeks, if that's acceptable.
Yeah, that's acceptable. Okay, we'll leave that open. Thank you. Then we come on to reviewing the meeting effectiveness. It will be picked up at the next session, which is listed for the 15th of June, was a board development session. So we'll leave that open too. We then move on to an action around the patient's story. The action rested with you, Nick. The update is to keep it open until May. Is that still the plan with you and Lucy?
Indeed, Chair, yes. Still waiting for some further information to come in.
Okay, all right, so we'll leave that open too. We then come on to the QAPR and the position around stroke. An update is provided. I anticipate we'll end up discussing stroke again when we come on to the performance report this time around. If you're happy, I'll leave stroke until we come to that discussion, and we'll close that off of here. Primary care update. This was circulated to the board on the 17th of May, so it says yes, close if Lucy and Chris are happy. John, you want to come back in?
Sorry, Mark, slightly early maybe, but it's both the item on stroke and the next one on stroke on item 17. There's reference, I pick it up, the item 17, it was about reporting back to PFIG, and I'm not sure that the response in item 6 actually says how PFIG committee is going to be updated.
Right, so I'm assuming then you've not received an update to this point, John?
Not that I can recall, no.
Right. Jill Sue Hill, that was listed for you 17. What's the intention around providing an update to PFIG then?
So I'm happy to take an update to PFIG, to the next PFIG, John, with Sue.
Okay.
John, does that satisfy you?
Yeah, it was just a response in the action log, sort of refers it back to the previous item, and it doesn't actually, procedurally, it doesn't say how we were going to close that off with regard to the committee, but if we get something back to committee, that's great.
Okay,
Thanks,
we'll be discussing it later as well, as I say, I anticipate. Okay, thank you, John. So the next was in terms of the corporate risk register. You were going to review the content around the informatics infrastructure. Dalan, I know you're in the meeting today, but that looks as though that responsibility has shifted to you. Is that correct?
Yeah, yes, that's correct, and I'm picking up that with John, funnily enough, this afternoon.
Okay, and welcome, Dalan, here. When you are ready, an update more broadly on, and I know you and I are discussing on to
yes.
board on your intentions, aspirations, and your stock take would be helpful.
Yeah, no, that would be something to look forward to. Thank you.
Thanks, Dana. Okay, I will move us on then to the 17 we've dealt with. 26. That has been picked up, so that's closed. 27 is closed too. 28, Sue, there's an action there for you that I know you've been responding to, but there's no update.
Yes, sincere apologies that this was missed, Chair. We have got the data in terms of ward clerk vacancies. We're just collating some of the additional data in terms of the progress against having more people on wards to answer the phones and feedback, because they were slightly different from ward clerks. So as soon as I've been able to link back in with Jill and team, we'll circulate that information. So apologies that the update was missed.
Okay, thanks, Sue. Thank you. 29, I believe I've dealt with in the conversation with Matt earlier on, unless you tell me otherwise. Then we come on to summary action log, which has been revised. I think there's still scope for improvement, but it's moving forward appropriately, I think. John, on that note, I know you had concerns about the references to reviews, John G, and being clear about timelines, which I think Philippa has sought to address as best you can at this point. But did you just want to highlight your concerns?
Yeah, it was just a general concern really with regard to not just this document, but a number of the reports that we've got presented today where we're referring to conducting various reviews, but there are no effective timelines put down in place, both for the completion of a review and potentially when any actions could come forward afterwards. So I just think in terms of good governance, we just need to be very, very clear that when we're talking about reviews, that we've got some clarity with regard to appropriate timelines and how that will then be reporting back into the board or relevant committees. Thank you.
Thanks, John. Joe?
John, Chair. Yes, we will pick up that helpful feedback. Thank you very much.
Thanks, Joe. And we'll keep it up.
Thanks, Joe.
Thank you. So 31, targeted intervention, that's on the agenda. So I don't propose to discuss that further. And I think the actions we agreed are now closed. Same applies, I think, to 33 in terms of the INTP, unless anybody tells me otherwise. People and organisational development strategy, there has been some considerable discussion on that front. I know at PPH last week, and Linda has updated me, and we'll come on to that because it's on the agenda too. The operating framework is in a similar position on the agenda, so I'll move on from there. Likewise, 37 and the CCTV policy, I understand, has been shared with John because that's the update. So we'll close. Vascular service and meeting was taking place on the 23rd. A number of things were agreed, and we've got an update on the agenda also, so I won't dwell on that action. Lucy had an action around the quality and performance report. There has been ongoing work, I know, with the lead members about the content of that report. I've also spoken to the performance lead, Amanda Lonsdale, and we expect to see that return as proof of concept at the meeting in July. So I'll move us on from there too. In terms of primary care metrics, there are some in the report today, actually, but I'm sure that's will be an ongoing conversation between Lucy, the primary care team, and others. And I certainly discussed that with Amanda when I spoke to her. And then the remaining actions are shown as closed too. I won't dwell on those because most of them are on the agenda in a similar fashion. Are you happy that we've dealt with the actions from the last meeting? Yep.
Yes.
Thank you. Okay, so we then come on to the update from me, and we have the executive report. The executive report from Joe, which may ask you to highlight. and describe to you. In a very challenging situation in terms of some of the performance concerns that we have discussed previously and will be highlighted today, the number of adverse reports that we are seeing from Health Inspectorate Wales, from our own internal audit, from Audit Wales and from others. And we have a number of serious incidents and NEPA events arising too. So we are in the midst of a very challenging period and situation, and we need to demonstrate that we are, as a board, recognising that situation and responding accordingly. That led Joe and I to have quite a lengthy conversation around the long-term direction for the organisation and the delivery mechanisms that are in place and will be put in place if we agree the operating model, the nature of the adverse reports and incidents and other matters that we are seeing and that some of us have discussed at various times over the last few weeks, and also in terms of leadership, governance and assurance. Now, as I said a moment ago, Joe will speak in a moment. Joe remains convinced as the Chief Executive that the priorities that we've agreed and described in the plan are the right ones, and the operating model, which, as I say, we'll be discussing later, is the right delivery framework for moving the organisation forward and to increasing confidence in terms of delivery against those priorities. Of course, the board, we will need to form our own view on the operating model in due course, but I do like to feel that we can support our Chief Executive in her aspirations and in providing our confidence in her and what she proposes in terms of moving the organisation forward, and which I've just referred to, along with her team. However, both are going to take some time, both in terms of delivering the priorities set out in the plan, albeit some of them are more short-term in nature, of course. But in the meantime, we are going to have to ensure that we have a greater level of confidence than we have had around the adverse reports, incidents that are arising of course, more of immediate concern. And they are requiring urgent attention and are receiving urgent attention, as many of you will know. Concerns have been highlighted by staff, and particularly nursing staff at Ysbyty Gwynedd, and they are also being examined as a priority by Sue Green and Gaynor. I know that Gaynor has been across the site only this week. I know that Sue and Gaynor are collaborating over the response that's required from the hospital management team, supported by the executive team. And I know they are meeting one of our assembly members, and I'm meeting them too separately tomorrow. So that there is a response in train to those concerns that have been highlighted. The approach being taken to improvement on the Ysbyty Glan Clwyd site is also due to be considered by an extraordinary QSC committee meeting, which is sitting today after this board meeting, and will be followed by a broader meeting in terms of membership that's set for the 15th of June. Immediate steps have also been taken to address the significant issues highlighted by HIW at YGC Emergency Department, but more clearly needs to be done in that regard. And I know that Nick, Jill and others have been spending a considerable amount of time on the site with the HMT and in that department to better understand the challenges they face, the responses to those challenges, and also what they can do to support our staff on the ground in terms of addressing the concerns that have been rightly identified by HIW. And I was across at the site, and I know other independent members have been across at the site too, to demonstrate our support for the work that's required. And then finally, in terms of the never event serious incidents regulation 28 notices issued by the coroner and adverse audit reports, they are also being subject to significant scrutiny. And I know that Medwin, as chair of audit committee, has certainly been focused on the latter with colleagues, and we know that there is more work to be done, particularly in terms of the nature of some of the responses being provided to those audit reports. But we'll pick that up further outside of this meeting. What I would say, though, is that there are a number of consistent themes. And for me, these are the following, and I think we all recognise these as members of this board. The first is the adequacy of leadership across the organisation. The second is whether there is sufficient clarity on the discharge of responsibilities and accountabilities. We've identified that some of the governance and assurance mechanisms in the organisation are relatively weak, and we have also discussed, and will discuss again, the culture within the organisation and the extent to which it's enabling, supportive and open, a topic I know we'll come on to when we talk about the operating model. What I would say is that if we are to be offered the opportunity to realise our longer term ambitions for our patients, staff and our communities, then we need as a board to better address the themes I've described and in a sustainable fashion. For me, the operating model will assist, but we need to be confident it will afford the opportunity to address the issues that I've described, and I know Joe recognises. And we must ensure that we take these opportunities as a board and we don't miss them. And for example, ensure that responsibilities are very clear and that governance is very strong, and that those issues are not weakened by a new operating model, but rather strengthened. I would also suggest that we need to be more assured about the effectiveness of the actions being taken to recruit, retain, develop and support the workforce that we need. I know this was focused upon by our PPH committee on Friday. I know a deep dive is planned, and I feel sure that we're all keen to support Sue Green and her team in taking the actions that they must in support of the organisation to develop and support our workforce, which is clearly a feature that's arising more than more. Similarly, there are plans to improve leadership within the organisation and to select and develop better leaders, and understand also how we will improve the culture of the organisation and how they will assist us to do that. Be assured that that topic is set for discussion by us as a board at our next development session on the 14th of June. However, in summary, I want to say this: given the pressures and focus we all recognise that we are under, I want to encourage us as a board to focus as individuals and as a collective, as an integrated board, on what contributions that we can individually, as I say, and collectively make with regards to the issues that I've identified, I know Joe and the team recognise, and that we must all contribute to, so as to ensure that we exhibit the leadership that is rightfully expected by our staff, our patients and our communities. And I seek your support in that regard. I will stop there and I will hand over to Joe.
Diolch yn fawr, Chair. Thank you. The leadership of BCU, including ourselves as integrated board, has clear work to do to support staff to provide the best care and support to patients and for each other. There is ground to make up as we move out of the pandemic in re-establishing norms of performance, particularly but not exclusively in hospital care, as we remove safely social distancing, which in itself will allow us to re-provide around 100 inpatient beds across all of our sites, to increase theatre utilisation, the number of operations that we can do, and to be able to offer more diagnostic tests and outpatient appointments, a very important time. But more than this, there is work to do in response to the clinical concerns raised by Health Improvement Wales inspections, by other regulators and interested persons, and through our own improvement and governance processes. Some of the issues that are raised, documentation, observations, patient falls, for example, have proved to be challenging to resolve over time and relate to services across BCU. Some of the issues are more basic in their nature and should and are being resolved. And there is work to do to strengthen our governance and assurance processes so that we can support staff to improve, help by feedback on how their improvements are working, and to satisfy ourselves individually and collectively as an integrated board that improvements do stick over time. This work, which is planned as part of our operational model, is being expedited. I have reflected on our clinical and cultural change approach using an evidence-based programme, which is proven to improve outcomes, patient experience, staff involvement, and the development of a safety culture, which importantly has been endorsed by Welsh Government's own improvement agency and perfectly mirrors the methodology they wish to roll out across Wales. We are using established healthcare improvement methodologies which have proven to deliver results within the UK, elsewhere in Wales and internationally. We're using this approach to move from individual improvement plans to a more systematic approach to improvement based on risk, and put simply, listening to staff about the changes and improvements they'd like to see, taking into account human factors in implementation, and then reviewing progress systematically.
Is it just me that's lost Joe?
No.
No, I'm
No.
lost.
Okay. What I will ask Joe to do is to share with you what she has said and was intended to say in the rest of that address to you, and I'll seek to ensure it's published also onto our website. Is that okay with everyone?
Yes, thank you. Yes.
Okay, all right. I'm sorry about that. I believe Joe is at Carlton Court. A job for Dallin, I think, in terms of sorting out that IT problem at Carlton Court, if that is the case. It's rather embarrassing that our chief executive cannot join a public meeting for our own headquarters. And Dallin, I'd seek your focus and assistance in resolving that, because it is really casting the wrong impression of this organisation and also affecting our reputation. Dallin.
Hello, yes, yeah, no, I agree with that. And just to let you know that work has already been initiated to understand what is happening at Carlton Court. There's already been some surveys done around the Wi-Fi and the like, so we're on that already, just to give you that assurance.
Thanks, Dan. And can you keep me updated, please, as chair of the board?
Certainly.
Thanks very much. Okay. I'm going to move us on. So I'm going to take us to the targeted intervention improvement framework. Jill, are you leading on this for me?
I'm happy to lead on this, Mark. I know it's under Jo, she's not here, but I'm happy to do so. Want to describe the improvements that we've made over the last few months in terms of strengthening the targeted intervention process. And Mark, you alluded to it in the action log earlier, in terms of having the checks and balances with IMs in the room to actually assess the evidence and assess the scoring. And that has been a really positive experience. It's been a really challenging experience, and it has resulted in some adjustments to the scores that were put forward. So I think that strengthens the robustness of the process. We've also taken heed of advice as we've moved forward and strengthened the chairs and vice chairs of the outcomes group and the evidence group to ensure that there is complete objectivity between those presenting the evidence or outlining the outcomes and the chairs and vice chairs of those groups. So that action has taken place. Within the paper, it describes the scores that we are putting forward for recommendation, and you'll see on page 3 the adjustments that were made as a consequence of that system moderation meeting that was held earlier this month. So the recommendation in terms of the scores, but also the target setting moving forward. There is one point, Mark, I'd like to really emphasise, and it was emphasised during that moderation meeting, is the leap between level 2 and level 3, which is looking towards embedding the evidence, is quite significant. So where you do see that the targets, the recommended targets for November, I'd like people to acknowledge that there is a significant difference between a level 2 and a level 3. I'm sure both myself and those that are leading each of the matrix elements will be happy to take any questions.
Thanks, Jill. Okay, I'm going to open it up to questions. Ben, any questions from colleagues? No. What about from the leads? I know I've not got Linda here, nor Nikki, who I'll come on to because I've spoken to them both. Okay, Claire.
Deal, Chair. Sorry, I was struggling to get my sound and camera on. It was a question really about the engagement area of improvement, and I think all the examples that are quoted in the paper are good, but I guess it's just a request that we think about how we might make better use of some of the more formal parts of our governance structure around engagement. So I'm thinking about my role as chair of the stakeholder reference group, and obviously the professionals group. So I guess it's just a request that we, I think for the future, think about, and also then we can include in the paper what we're doing to kind of build the input from some of those formal structures as well. Thank you.
Chair, thank you. I will take that away, Claire. I think it's a really helpful observation. I think one of the conversations we've had within the group is how we move forward. We've done a lot of work on engagement, move forward considerably, but there is still work to do. So I'll ensure that we take that outside, Claire, and link more strongly across to the work that you're doing.
Welcome back.
Jill, so you are aware there's a conversation that's taken place between Claire and I, Claire as chair of Stakeholder Reference Group, and also with Jane as chair of the Health Professionals Forum, to ensure that those groups are more adequately represented and influential, most importantly, in the way that Claire has described. So I do think we've got to keep a note of that moving forward, and I'd expect to see, in terms of the assurance reports from Jane and Claire, more challenge, if challenge is necessary, about the extent of our engagement with those two forums. So
thank you, Chair. I do note that it's on the Health Professional Forum's agenda. That I would re-emphasise, though, the point that has been made that we use our own governance channels, so we reach out to our staff and stakeholders in all of the opportunities that we actually have. And hopefully, as we move into the new operating model, we can maximise the opportunities there as well.
Okay, thank you. Jane.
Yeah, hi. I just wanted to reiterate that HBF welcome members being part of the evidence and outcomes group. So 2 members of the HPF do sit on those groups as well. So I just wanted to highlight that as a welcomed addition.
Thanks, Jane. Cheryl, I think you're wanting to come in.
Yes, thank you very much, Chair. Yes, just to say, as the lead I am for all ages mental health, I'm now comfortable that due to all the rigorous scrutiny of all evidence that we are happy we are settled now on the scores required, and I'd just like to thank everybody that's made such an effort to include me in absolutely every decision. So that's great. Thank you.
That's good to hear. Thanks, Cheryl. Lucy, your hand was up. You still wanted to come in?
I'm okay, thank you, Chair. I was just going to comment on what Cheryl's just said there. I think it's just important, though, to highlight that as we increase from the schools, as we go through the maturity matrix, there will be a gap between the implementation and achievement of the actions in the maturity matrix and actually seeing the improvement in the outcomes. I think to a degree we need to hold our nerve in relation to that time gap, and we discussed this with the Deputy Minister last week. But it's being very, we need, as a result of that time gap, though, we need to be very confident there's evidence base, very clear evidence base behind the implementation of and progress against the actions. So I just wanted to highlight that.
Thanks, Lucy. John?
Yeah, it was just to pick up on the recommendations for target setting for November 22. There is actually an ask there for us to formally ask Welsh Government to split the matrix, and I'm sure the board would probably agree with that, but I just think from governance we might need to pick that point up.
Thank you, John. You're absolutely right.
I will pick that up. Thanks, John. Before I offer some observations myself, Jill, do you just want to, or Joe, do you just want to relay your assessment of the targeted intervention meeting that took place, I know, with Welsh Government officials last week? I know other actions were agreed, but I suspect there would have been a discussion around the gradings that are proposed in here. So do you want to give the readout from that meeting too?
So can I ask if Joe could do that, because I was on leave last week, so I didn't attend the meeting, so I couldn't give you the full emphasis.
Joe?
Apologies for the earlier connection issues. We had a meeting with Welsh Government, Mark, as you have indicated. Welsh Government colleagues confirmed that they were comfortable with the proposed scores that we are suggesting for discussion and agreement today. They are working with us from a maturity matrix targeted intervention point of view from our improvement aspects. Now, there are other opportunities that Welsh Government have to raise issues of performance management with BCU, and issues of concern are regularly discussed between ourselves and Welsh Government. The targeted intervention forum is an intervention for us to discuss our shared improvement endeavour. So on that basis, colleagues confirmed that they were comfortable with the scores, that they understood the process and the governance behind the identification and development of the scores at the place they are, and that they appreciate that making progress in a measured and sustainable way is particularly important. Thank you.
Thanks, Joe. And then as I alluded to, I've had exchanges with Linda, who of course leads on the leadership, governance and culture domain on behalf of independent member colleagues, and also with Nikki this morning, who leads in that regard for strategy, planning and performance. And I think there are a number of observations that resonate with matters that we've previously discussed and that have been alluded to here. So the first is, from Linda's perspective, the PPH committee, of course, took place last week, particularly though in terms of workforce, but she wants to contribute to the design of the session that we've arranged for the 14th of June on leadership with the King's Fund. And there is an opportunity for both her and Nikki to do that, because there's a steering group meeting beforehand. But Sue, G, you are working on the design of that session. I don't want to go into detail now, but it might provide some assurance for you to say what the plan is, because we all want to see that leadership, governance and culture score move forward. Some headlines from you as to what's planned.
Okay, so I think, so what the discussion that we've had and with King's Fund and colleagues is that there needs to be greater alignment with the work that we're doing as part of our greater visible alignment with the work that we're doing as part of our board development, with the outcomes that we've expressed in the leadership matrix, rather than it being described as we're going to have a session on targeted intervention leadership matrix. It's more about connecting back to the outcomes that we've described and making sure that that drives more of the agenda, explicitly drives more of the agenda than perhaps has previously. We know that it has driven the agenda, but we've maybe not been as explicit and therefore not connected the work that we're doing and the outputs with the outcomes that we have described and we are evidencing, and that has been one of the challenges with the outcomes group, particularly in being able to evidence that moving back through. So it's really, the session is predominantly around joining the dots between what we are doing, the work that we are doing and the contribution that the colleagues are making to that, with the outcomes that we've expressed we should be seeing if we reach the different levels of maturity set out in the matrices. Hopefully that gives colleagues a little bit more insight into that work. It's not that we've not been doing it, it's just it's not been as explicit and therefore more difficult to evidence in terms of outcomes.
Right, so we'll come back to that topic on the 14th. Thanks, Sue. Right, then the other substantive observation made by Nikki was the one that Lucy made and that we've discussed previously. And that is ensuring that we avoid focusing on process and lose sight of the improvement required and also the outcomes that need to be delivered as part of the work on our targeted intervention framework, as well as the other work that we do to improve our performance. And she's right. Nikki, by the way, supports the request to seek permission to split strategy and planning from performance. There has been a conversation, as I understand it, around what I've just said in terms of the focus on outcomes within the domain conversations that Nikki has been having. But I think, Joe, that we need to ensure that we land that point upon separating the domains out and ensuring that the focus on performance is one that's also aligned to outcomes that should be achieved through the work we're doing on targeted improvement. Does that make sense, Joe, first of all?
Yes, yes, it does, Chair.
Right,
we will have that work.
The second thing is, and I think we can discuss this on the 14th, is that we've previously discussed, Joe and colleagues, the opportunity to focus differently on board to ward assurance, and for example, through deep dive activity in terms of us devoting some time as a board or as a subset into examining areas of particular concern or indeed areas of particular opportunity and improvement. That will also afford the opportunity to ensure that we are providing leaders in the organisation and others with the opportunity to join us in those conversations and understand why the board is operating in the way it is and so on and so forth. Sue, I've already said in an email exchange I'd like us to pick that up on the 14th. But in the meantime, Sue, I know that you've agreed with Linda to do a deep dive around workforce issues on the back of the conversation last week. Perhaps we could, if you like, use that as a pilot. We haven't got a process. I think we need to agree how we are going to approach a deep dive, how you might extend the focus beyond yourself and your team. And perhaps, as I said, we could use that as the first attempt to get this sort of activity right and then to build on that moving forward.
I think that's a good plan, Mark. Thank you.
Okay. Joe, are you happy with that?
Yes, I am. Thank you.
Right. Okay. Are there any observations? Sorry, I am recovering from COVID, so I've got a bit of a chest problem, which is why I keep pausing and breathing. Are there any other observations around the targeted intervention improvement framework papers, and also the scores that are now being advocated for our agreement? No? Okay, so the board is requested to note progress in terms of delivering targeted improvement, to agree the self-assessment reference points against these matrix, which are listed at the start of the paper, to agree the target reference points for November 2022, which are also listed, and to request permission for Welsh Government to split the strategy, planning and performance into 2 domains. Are colleagues happy to do what's been requested of us and to approve what I've just described?
Yes.
Yeah.
Yes.
Thank you. Okay, I'm going to move us on then, again, if I may. Move to the next item on the agenda, which is the COVID-19 update. Jill, which is for assurance purposes.
Yes, thank you, Chair. I'm not going to go through the whole detail of the paper. I just want to give the highlights, if I may. As you will have seen throughout our communities, the impact of an incidence of COVID has reduced quite considerably. And as a consequence of that decision to step down the formal gold-silver structure is asked to be supported. We do have in place intelligence cell that is still providing us with intelligence as to the incidence and impact of COVID across the health board, and that will enable us, should the situation change, to step up our procedures and policies should that be required. We do continue with a level of the controls, and now we continue with our vaccination program, for example, which we're currently at 72% on the cohorts that we are now vaccinating, with 5 weeks to go. So we're still making considerable progress in those areas. It is suggested that the pseudo silver role is taken over, or the tactical role is taken over by our EPRR lead, supported by the head of Tactical Control Centre, to support the impact of the operational delivery across the system. That is in fact in place and is working. We are still receiving updated guidance from Welsh Government, not least in terms of the changes in COVID controls within the health services moving forward. Those are being taken through the executive team. We have agreed that there is a central communication so that we have the communications logged into the organisation, and we can be confident that they have been received. Happy to take any questions. I think the only other point I would make, Mark, and I'm sure that Teresa will endorse this, we're conscious that there is a lot of noise in the system currently about monkeypox, so we are aligning that with some of our surveillance as well, and any decisions that need to be made around that, particularly around PPE, for example, we are taking forward and logging.
Okay, thank you. And Teresa, I'm aware that you've got to leave at some point today. Can you update us when you've been there, perhaps in the private session, on the conversations that are taking place around monkeypox?
Diolch yn fawr iawn, Cadeirydd, yn siarad yn Gymraeg. Dwi wedi ffeindio rywun cyfaill i fynd i'r cyfarfod arall, mi gai diweddariad a na i diweddaru'r bwrdd nes mlaen. Diolch yn fawr iawn, a diolch i Jill am y diweddariad hitha hefyd.
Diolch yn fawr, Teresa. Any questions for Jill? Yes, John.
Yeah, it's just an update in terms of hospitalisations. I mean, the report clearly is showing that progress is being made, and the impact now, perhaps in some quarters, is not as high. But Jill, it might just be worth flagging up the number of cases that are still in hospitals. Otherwise, the public may be assuming that that sort of risk of hospitalisations has actually gone away?
Thank you. In terms of the absolute numbers, I'm happy to provide those and put them online. But at the moment, the numbers are very low. But there is still a risk. We do still continue to screen our the patients that are being coming in for routine surgery so that we can mitigate the risks along those. And we are now considering the new guidance that's come in from Welsh Government, which is looking at a significant downturn in some of the processes that we currently have in place because of that reduction in incidents. What we are still seeing, and dare I say it, our chairman is an example of that, is very much that it is still in the community, but the severity of the illness, and thanks to the vaccination programme and the work that's been done there, is not requiring significant hospitalisation, and certainly not into our critical care environments.
Thanks, Jill. Thanks, John. Cheryl.
Thanks very much, Chair. Thank you for that, Jill. And again, our thanks for you and our colleagues, all the continuing work on this. In terms of community questions around COVID, the one I get asked most, and I know it's one we've been asking of yourselves, when are our GP surgeries going to be opening back up in terms of routine appointments? I'm thinking very much around the preventative agenda and the impact on our EDs. That's a really, really important topic that I've got asked all the time. I wondered if you could give me your thoughts. Thank you.
So I think this I think in terms of where we are, Cheryl, I think I would reiterate that our GP surgeries are open and they're doing significant amount of virtual work alongside, as you say, the face-to-face work, and that is, we are seeing the impact of that. Clearly, the guidance that has literally just been received into Welsh Government will have an impact across all our services, and we are considering that right now. So I'm quite happy to update you once we've had the full consideration of that with our IPC teams.
Cheryl, Jill. So I don't have any further items raised in terms, or hands raised or questions raised in terms of this item. So I'll stop there. Thanks for the update, Jill, and it's good to see the position is improving. Thank you. And thanks to all the work of our staff in that regard too. There is an item for consent listed next. That is the normal Mental Health Act report. Are colleagues happy to approve the report and the recommendations therein?
Yes.
Yes.
Yeah. Thank you. Okay, we now move on to a comfort break, which I intend that we shall take. We are running early, which makes a change and is also good to see. I suggest that we come back, if you are content, at 5:02. Is that okay with everyone?
Yes, thanks.
Yes.
Thanks. 5:02. Thanks, everyone. Got that. Okay. I'd like to resume the meeting, and we are going straight to the operating model. Sue, are you ready to kick off?
Joe is going to present this item. Thank you, Mark.
Sorry, this on my
No,
resume. No?
Don't worry, Sue is going to help me by sharing some slides. Thank you, Sue.
Thanks, Joe.
Thank you very much, Sue. Could you take us on to the next slide? Thank you very much. So we have discussed the operating model as part of a series of discussions across the organisation in order to develop the preferred operating model, which in turn was based on feedback from staff as part of our listening exercise, and from feedback from other partners around the changes we needed to make in order to better be able to respond to the health needs of the population of North Wales. So the operating model, which was approved by the board at its February meeting on the 3rd, does move us to a place-based delivery of care model, supported by the development of structures that can work across North Wales for some of our services, and can provide oversight and governance in a consistent way across North Wales. Next slide, please. In bringing this paper to the board today for consideration, we have been planning for go live consistently and diligently. And in order for us to go live, we do need to have a series of building blocks absolutely in place. And those I outline on this presentation. Thank you, Sue. Next slide. In working through the executive team's assessment of readiness prior to go live, we have noted that there are some aspects of change which are not essential to be completely in place from day one, but will be required to be finalised during the course of implementation. And I've outlined those on this slide. So we're very clear about the structures that are in place and have been agreed through our governance processes around the top tier, the most senior appointments to our structure, not only within our place-based health communities, but across the organisation as a whole. And we are keen to continue the work that we have put in place with regard to co-design as we move to finalise the structures underneath the top tier. And whilst we have been very resolute in our intention to ensure that governance arrangements are completely consistent across each of our operational structures, we're keen to ensure that the new senior leadership team in each of those structures are able to work with the executive team and absolutely within the governance framework that we are prescribing to develop structures that allow our delivery of services to reflect the undoubted differences across the whole of North Wales, and acknowledge that in working in partnerships, particularly but not exclusively with local authorities, there are legitimate differences from place to place in how we might deliver services, but with a very consistent set of requirements in terms of the delivery of patient outcomes, strong patient experience, and the delivery of the performance management expectations that we are working to, not only from our integrated board ourselves, but also from Welsh Government. We are continuing to do work with regard to aligning support services. Some of these support services are within our existing delivery model aligned to localities. There is a little more work to do in order to align those. And we are planning further work, particularly around primary care support and leadership. Those aspects do not need to be fully in place by go live. Next slide, please. In thinking about our governance model, which we have done over some time, and I would like to acknowledge and pay thanks to Lucy Reid for her contributions to this work. Lucy has met with Simon Evans and other colleagues in helping us think through some of the governance challenges. So thank you very much, Lucy, for your input. The governance framework that we have developed does aim to bring together key governance processes to develop a performance and accountability framework that is consistent and clear, and clarifies routes for escalation up and down the organisation as a whole, and enables us to deliver a consistent risk-based approach to governance and assurance, and does respond to some of the requirements that the chairman outlined at the top of the meeting with regard to clear local responsibility and leadership for governance linked to corporate functions. We are wanting to create an environment where our clinicians can be enabled to deliver the best quality care within a safe governance arrangement, which neither ties their hands so they have to ask for permission for everything, but nor gives complete freedom and flexibility for individuals to be working outside our governance framework. Next slide, please. Our structures are designed to be coordinated, to be evidence-based, to be consistent, and allow us to deliver the board's strategic objectives, strategies and priorities consistently through our organisational structure. And that each of our governance processes must be defined through the health board governance structures, with any variation from that only to be agreed following careful consideration. We want to make sure through our governance arrangements that we are clear about individuals' obligations to escalate depending on the individual's performance. So we may have a situation, with the group's performance. So we may have a situation where performance in a particular aspect of work or a particular area is incredibly strong. Freedoms within our governance framework may be appropriate, as Welsh Government do with us. And there may be areas where performance needs a closer oversight and scrutiny, again, consistent with the principles of governance that Welsh Government apply to us. We're also seeking through this process to align floor to board assurance based on a risk approach through a series of routes, including those which I've outlined on these slides. No. Thank you, Sue. Thinking about assurance, which is again aligned to the opening remarks of the chairman and would have been to myself, notwithstanding the technology glitch. We want to, through this model, utilise the 3 lines of defence assurance model, so not reliant on line management responses alone. We are developing, as part of our phased implementation of the operating model, a revised approach considering risk, assurance, clinical effectiveness, and quality and safety, and ensuring that that enables us to triangulate quality and safety regulators that work across the health board. This integrated assurance approach will allow us to be able to take a more proactive and forward-looking approach to risk and risk management. Triangulation in this framework does include examples such as clinical audit, internal audit, ensuring that our internal audit profiles are risk related and linked to our organisational improvement priorities, ward accreditation, informal and more formalised walkabouts, feedback from CHC, no notice and planned visits, and patient feedback, and so on, with a quality assurance process around evidence to ensure that local action plans and learning is shared consistently across the health board. We, thank you, Sue. There are risks for us in implementing any operational model change. There are risks for us in maintaining our status quo. It's my advice to the board that we are better able to move forward to deliver the results that we need for the population of North Wales by implementing the operational model at the timeframes that I outline in the paper. I would just like to confirm that oversight of the governance model sits with Jill as our Deputy Chief Executive and as our governance lead. I would suggest that we work to finalise the outstanding questions that we have with Jill as Deputy Chief Executive, taking the lead with Lucy as Deputy Chairman, and that the board delegates final sign-off of these aspects of work to myself as Chief Executive, to Mark as Chair, to Jill as Deputy Chief Executive, and to Lucy as Deputy Chair. Very happy to take any questions, and I would be supported in answering those across the executive team, as you would imagine. Thank you.
Thanks, Jo, and thanks for the presentation to accompany the papers. Okay, I'm going to open it up. Any questions or observations, please? Lucy.
Thank you, Chair. Yes, I met with a number of the executive team on Monday to discuss the documents before us today. Unfortunately, there are a number of errors in the documents, and we discussed the general principle of some quite key information missing, which Joe has actually quite nicely just filled in some of those gaps. From my perspective, I would say that I absolutely support the principles of the operating model as it's been put before us. There are a number, as Joe has indicated, there are a number of elements of the operating model in the papers before us that have already been agreed, including, for example, the top layer of the organisation down to sort of the creation of the health communities. In terms of the governance model, again, I support the principles of that and support the ambitions of what Joe has just described in terms of trying to make sure that we've got the right governance in place. And it clearly needs to be strengthened, our assurance procedures. We've discussed that as well. The recent HIW reports and QSE committee meetings have demonstrated that we really do need to strengthen our assurance, and again, fully support the intention of doing that. I think what I would say is that the documents before us today that we're being asked to approve are, I've described very much as still work in progress, and I welcome the opportunity to continue to advance that with Jill and the team. I'm happy to provide any support I can on that. It's absolutely essential we get this right. We are carrying quite a lot of risk at the moment in terms of trying to progress with this model. I'm clear it is the right model, but we need to be clear as well on the implementation, and the implementation's got to be right. Thank you.
Jill and then Lucy. Sorry, Jill and then Sue Green, sorry.
Sorry, I thought that's what you meant, so thank you. So Lucy, can I thank you for your offer of support as we move forward? I think it is critical now that we move into the next phase of the operating model, and the intention is to learn, as you've described, Lucy, from conversations at QSE and elsewhere regarding our assurance model. So the separation of those checks and balances, and indeed the intent to ensure that we are receiving reports and that is being followed through corporately, will also ensure that the assurance that we receive is consistent across the health board, and that will not be is not an intention to delegate that to localities or divisions.
Thanks, Jill. Sue Green.
Sorry, Mark, I think John has his hand up as well. I think he was before me.
He was, but I wasn't sure whether you were seeking to respond to Lucy. If you were, I was providing you an opportunity to do so.
Okay, thank you. Sorry. So my comment was going to be in response to the errors in the documents. Take full responsibility for the errors in the documents. It's not an excuse, but trying to coordinate a range of work that's happening across different work streams. I failed to spot some of the errors in the executive chart and in the charts themselves. So they will, of course, be corrected before any publication of the document. The document is a live document. It is an operating model, so will change, but clearly it is going to be absolutely essential that we go through the document before go live with Helen and the team as well, because it will need to be translated, quite rightly so. But I wanted to apologise to the board for the errors in the documentation. It isn't those that we're approving today. It is the movement of the model, but nevertheless they should have been correct.
Thanks, Sue, for recognising that. Okay, John.
Thanks, Mark. And thanks, Joe, for the presentation. I think to preface this, I'm supportive of the model and what it's trying to do. It feels like we need to make that change. I think the areas that still concern me are around accountability and governance, and I'm still not 100% around how that's going to flow from, say, the new senior leadership team into the rest of the board governance structure. I think the other area is that concerns me is sort of the management of risk within this, because you touched on 3 lines of defence model, but I'm not sure how the risk have been assessed, say, for instance, in terms of impact on delivery of the IMTP in terms of patient outcomes or in terms of financial performance. If you're looking at 3 lines of defence model, have you done the sort of assurance mapping against those 3 lines of defence so we understand where potential gaps are in terms of that assurance from in the governance structure?
Who wants to respond? Jill.
Yeah, I'm happy to respond to that, John, and we'll be keen to have you alongside Lucy in developing what we're describing. You'll know that we have a new Associate Director of Governance starting with us at the beginning, or the middle of July, John. So we're working with him and others to do exactly what you've described. Let's do the mapping. Let's be confident about where those levels of assurance take place and what the overarching framework looks like, John. So I'm not going to sit here and tell you that we've done all of the above. I did outline that we're in work in progress, but we do need to lock this down, and we aim to do that before we go completely live. So John, if you would be keen to do so, we'd be keen to have you on board.
Yeah, just to respond to that, Joe, happy to provide my input if you want to include me in terms of discussions on the governance or the risk management side of things.
Thank you. And just to confirm, John, that the principles of aligning the risk management with that assurance as well, John. So there's a couple of conversations I would welcome your input.
Right, thanks both. Jill, I posted a question earlier on in the chat, which I need you to pick up when you get a moment. So, okay, I'm going to come. Thank you. I'll come now to Chris Stockport. Chris.
Thank you, Chair. I just wanted to come in on the back of the comments from Joe and from Lucy. So I think everything that Lucy said makes absolute sense, not least the fact that this absolutely is the right model to go forward with. I'm really clear about that in my own mind, and also that there are some risks in terms of moving this through and still some work to be done. I think what I really want to express though is the very big risk that we have whilst we're in transit. So we do need to get to that position where we can fully implement the operating model now as quickly as possible, and with as fewer risks as possible, taking into account, as I say, those risks that we are carrying whilst we're sort of part way on that journey. And so with that in mind, it would be fantastic if we could get to that point today of being in agreement to move forwards. But if not, the observation that or suggestion that Joe made in terms of whether or not that small group of 4 could be delegated with being able to move this forward before we get to the next board meeting, I think will be really helpful. We absolutely do need to get to a point of completing the journey now.
Thanks, Chris. Jackie.
Thanks, Mark. I'd just like to take us to a slightly different section of the model in terms of the engagement and communication with staff. I noted the comment in the slides around the structures below the top tier and developing a framework for those. And that is the area that is concerning staff most currently, as they are seeing all the changes and are anticipating that they will see their own service changing. So I think the engagement and comms plan gives us an opportunity to reassure and support all the staff in terms of that. And I'd like to say thank you for the plan. It seems very comprehensive. There is just one other comment regarding the drop-in face-to-face sessions, and a concern that we make sure that we don't rely overly on the use of the internet and other as a means of communicating those sessions. We need to make sure that staff are fully aware of where, when and how they access them, because not all our staff are IT savvy. Thanks, Mark.
Thank you. And Sue Green's hand has just gone up. Sue.
Sorry, Mark, it was a thumbs up.
Oh, was it? Okay. Okay. My eyesight must be going, sorry. Right. So rolling across the next few people on a comment. Jackie next, please. Oh, sorry, Jackie, we just done you. Morwenna. Morwenna, is that you that's got your hand up? Sorry, I can't see the identity on my screen.
Apologies, Chair. It's been me.
Okay, so you're under a completely different label to what I'd expect. Okay, go ahead.
Thank you, Chair. So I just wanted to address 2 points, if I may, in relation to a question from John Cunliffe. The first was about in terms of what the outcome would look like in terms of risk management. And I just wanted to kind of just highlight that we're going to put in place a devolved accountability and assurance infrastructure, which supports the delivery of statutory compliance, risk management, safety and quality. And it's also going to be aligned to the work we're doing with the risk management strategy, specifically focusing on some of the learning around risk appetite, risk tolerance, and risk escalation. So I just wanted to give that assurance that one of the most immediate outputs you'll see is a risk strategy, taking into account the strategy the approach I've talked about, but we'll be able to show you very clearly how the devolved accountability structure will feed from operational to the committee structure and feed onto board.
That's an important point. Can I just, though, comment further on risk? The overriding paper, the main paper, refers to the risks being built into the corporate risk register. One of the appendices suggests that work is still ongoing. Now, could you also tell me which it is, please?
Thank you, so I can comment on that. We've got a risk management group meeting on the 31st of May to consider and scrutinise and challenge the risks that we've talked about in our previous workshop on the operating model. They will be incorporated formally onto the corporate risk register after that meeting. What you have in front of you today is a sum total of risks, including the risk log. But I just wanted to clarify that the most significant risks will be looked at specifically at the risk management group meeting.
Okay, thanks. Sue, did you want to come in?
Yes, sorry, it was my wording in the report. So all risks are logged in Datix and have been logged in Datix. They have been subject to a number of reviews with the various exec risk owners. But as Molly said, the most significant risks are going to the next RMG for approval to move onto the corporate risk register. But they have and will continue to be managed through our Datix risk management system.
Thanks, Sue. Okay, and for Molly and your comments, I will move it on again. Sue Hill.
Thanks, Mark. I just wanted to provide assurance to Jackie around her comments around the large number of our staff who do not have access to IT. A lot of these are within the estates team, obviously, and Rod and his team are doing really good work in terms of getting round and having face-to-face meetings so that people understand the implications of the operating model for the teams. And I just wanted to make a point about the IMTP and the delivery of the objectives within it for this year. So the operating model and the people strategy are intrinsically linked to that cultural work that we've already discussed this morning and making a success of that. And obviously the IMTP is a real integrated model of delivery across both the support functions and the clinical services. And I think the sooner we can implement the operating model, the greater we'll be able to provide probability of delivery of that IMTP.
Before you end commenting, Sue, you and I have had an exchange over the last 24 hours about confidence in terms of financial control during the transition period. Your comments on that, please?
Yeah, so I think the team have worked really closely as part of the operating model transition team. And what we are clear on is that the existing controls will remain in place until we have that sort of binary switch of moving to the new model, and then we've got something in place that will immediately work around the accountability for the new system. I think obviously if you look across the organisation, people are distracted by the operating model and waiting for the sort of the moment to go. So I think the sooner we can do it, the greater success we're going to have around that switch. But everything is continuing exactly as you'd expect until we have the approval from the board.
Yeah, thanks, Sue. Cheryl.
Thank you very much, Chair. Mine is a question for Joe. Joe, how much discussion have you had with the directors of social services across North Wales and people maybe lower down in social care? Their concerns, as the last that I was aware of, where they were really concerned about the loss of lots of experienced staff, and also over the last couple of years we've built up really good pathways of information and meetings and collaborative working, and they were extremely concerned how this new model was going to affect those patterns of working. Can you tell me, have you resolved those conversations with them all? Thank you very much.
Thank you, Cheryl. I can confirm that I have had conversations with directors of social care, shared with them on a number of occasions, both documentation and my thinking. I'm aware that they have built very effective local working relationships and systems and processes that that underpin the work that we have done. It is my intention that we don't lose the good work associated with those local partnerships. In fact, the whole ethos around moving toward much more towards a place-based approach is to enable us to have even more connected conversations and to offer even more effective influence across the range of work that we deliver, rather than focusing more particularly on the work that happens within area teams. I know that social care colleagues have been concerned that when we talk about clinically led, we will perhaps move away from or into the medical model as opposed to the social model. And to be clear, and I have been clear with them in conversations, that it's not the intention of the model to move towards a medical model, either by assuming that clinicians are medics. Actually, we talk about all registrants, but also to say the ethos around the work that we want to do across the operational organisation as a whole not just at area team, is to move us into a much more thorough consideration of all health and wellbeing matters, not simply looking at acute in the current management structure at HMT and everything else across areas. I mean, clearly, it is a process of change, and we will and are going through processes now of ensuring that for those individuals who are leaving, we are clear and content that we farewell them well, acknowledge their service, but also make sure that their knowledge is transferred. We were clearly a team. Some individuals are leaving, but our relationships and our interdependencies between ourselves and local authorities are vested in more than one or two individuals. I can confirm that I've discussed the model with individual chief executives and in group settings. Whilst, of course, they acknowledge that our structures are our business, they were very supportive of the concepts around strengthening the place-based approach with that integrated consideration. The challenge, I think, for us is to make sure as we implement the model, the benefits that we've seen through the area structures are absolutely replicated. The relationships that individuals have developed with individuals are able to be continued, if not with the same individual, but strengthened as the scope of influence can spread wider. We all should be concerned, not only directors of social care, to make sure that we are able to deliver the design principles of the operating model, and that is to be personal, patient-centred, not delivery mode, acute or primary care centred, and that will be our collective task. I acknowledge their concerns. I do think the proof of the pudding now must be in the eating. Thank you.
Thanks very much, Jo. So could I just ask then, these conversations have taken place in the last few weeks and they've seen these papers and these presentations today, and they are content with this latest version. Thank you.
The conversations have been happening over a long period of time, either by myself or by colleagues such as Helen Stevens-Jones. I haven't personally spoken with them in the last few weeks, but I know those conversations have been had. I also acknowledge that colleagues do have concerns about the changes. I do believe we need to make those changes work and ally the fears of colleagues in the way we implement the changes. Thank you.
Thanks both. Richard.
Thanks, Mark. I welcome this report. I think it's a good step forward. I don't think there's much doubt that the operating model that Jo inherited when she took up her position was really unfit for purpose. I think that's been evidenced by a variety of things that we've seen and heard in recent months, as the Never events, the things that have concerned the Welsh Government, there's the things that have attracted adverse comment from the public and the media. There's serious things like that, but also there's other issues such as the sort of experiences that we heard about earlier on in the patient story from Mrs. W. I think there is a strong argument that if we'd had a good and effective operating model that worked, some or all of those things probably would not have happened. So any attempt to resolve the status quo ante and move us forward, I think is to be welcomed. I have in the past described the existing management structure as rather like trying to rationalize a plate of spaghetti. It is exceptionally difficult, if not impossible, at times to identify who has responsibility for something or who is accountable for something, and that's not a good situation in any organization, particularly one that deals with healthcare. So I'm greatly encouraged by things that I read in the documentation we've got, in particular, looking at Appendix 1, I think it is, the responsibilities of the Executive Medical Director will include responsibility for quality, the regulation and performance of medical staff and pharmacists. And I'd just be grateful if we can have some clarification that means that post holder will be responsible for monitoring and quality control of all clinical activities within the trust, for management of those issues, for resolution of problems as and when they occur, and for reporting any issues back up the chain of command to the chief executive and to the board. If that is the case, then hopefully we can look to see that there appears in due course a set of systems underneath that post holder to deliver against those important objectives. So I think that's the main part of my question, but just a couple of relatively minor things that I'd like to tack on the end. I remain a bit puzzled and unconvinced about part of the responsibilities of the Executive Director for Nursing and Midwifery, which will include legal services. I don't understand why that is there, and it strikes me that it would sit better in a more corporate position. And similarly, under the Executive Director for Public Health, we have responsibility for Welsh language issues. Welsh language is obviously an important thing for communication within an organisation in North Wales, but I would have thought the Executive Director for Public Health is a rather strange place to put it. Thanks, Mark.
So Nick, do you want to respond on the medical director points? And then Joe, can you respond to the other points about executive responsibilities, please?
Very happy to, Chair. Thank you. And thank you, Richard. The short answer is yes. The longer answer, I suppose, is the delivery of the health board is complex, and the executive team work very much in a matrix way. Whilst there's an absolute clear professional accountability to me for those groups, and one which is essentially unchanged from the current position, there are also some operational and practical issues which I would share with my executive colleagues on a day-by-day basis. But in terms of the professional accountability, absolutely mine.
Joe, the other point about, or questions about portfolios. That's your hand up.
Thank you, Richard. So starting with Welsh language, it's important that the Executive Director with lead responsibility for Welsh language is a passionate believer in the importance of Welsh language, understands the cultural sensitivities, and is a strong advocate for patients to be able to receive their treatment in language of choice. Clearly, it's also important that that individual is a fluent Welsh speaker, and Teresa meets the bill on all of those points admirably. So that is why Welsh language quite rightly sits within her portfolio. With regard to legal and risk, there are two aspects to our legal work. The work which is particularly pertinent to quality and safety is the aspect of legal and risk that sits within the Executive Director of Nursing. The wider aspects of the governance of our relationship with our legal and risk provider, which is an all Wales shared service, is shared between the Office of the Board Secretary and the Office of the Director of Nursing, to reflect to reflect. Sorry, Richard, those two subtle differences. Thank you.
Thanks, Joe, and thanks, John, for those replies. That's great. Thanks.
Okay, thanks everyone. Claire, and then Lucy, and then I will sum up. Claire.
Thanks, Chair. I guess I may be taking a slightly different approach to some of my fellow board members. I'm not going to comment or ask any questions on the detail of the structure because I don't really feel I'm equipped to do that. So I do support the proposals. I'd like us to approve this paper today, and I think I support them for two reasons. I want to give my support to the exec in terms of their thinking, experience, reviews of best practice that will have been taken, understanding of local needs and of our significant need to improve services to local people. And I feel that all those things have been taken into consideration in making the proposals that are put before us today. Lots of the questions from colleagues have been about what I'd call less about the structure, but more about the how, around how that structure might be implemented and looking to see how risk will be managed and how board members can have assurance around that. And I think the proposals around some governance input from two board members who volunteered to work closely with the exec around that, I think does give us assurance as a board. I suppose, and board members have heard me say this before, I guess the biggest issue for me is less about what the structure is and more about the culture in the organisation, because any structure can deliver great results if people are all aligned around the same vision and are all working to achieve the absolutely best possible services and healthcare for people across North Wales. And I know we've got our people strategy paper on next. So I look forward really to understanding more about how we're going to work together around improving culture, because that is the thing that will improve things for people of our region. And apologies, I thought I had my camera on, I've just realised I haven't.
You did, and then you didn't. Thanks, Claire, for those observations. Lucy.
Thank you, Chair. I know you're going to wrap up on this, but I just wanted to just reiterate really that as Jill has indicated, a number of these issues will be tested as part of the governance piece. The issues regarding the executive portfolios, there are errors again in that document, so that's my understanding is we're not agreeing what is exactly in the document today. But that we need to be clear on what we are approving today to enable the right things to be moved forward, as Jo covered during her opening piece to this, and we can wrap round some of that to make sure that we're enacting the right things in the right way. I completely agree with Claire's point that, and there is a cultural piece that really needs to be done, and I know that is one of the work streams in relation to this piece of work to make sure that we get this right.
So can you keep it brief, because I don't want to feel as though we're going around on the same points, and I want to get to the decision, please.
I will do, Mark. It's just to clarify, the board isn't being asked to agree the executive portfolios today, because those executive portfolios, notwithstanding the typographical error in planning, have already been approved by Remuneration Committee. So, and they will be going back to Remuneration Committee following some decisions that have been taken in recent RATS meetings. So just to clarify, not being asked to approve the executive portfolios today. Thank you.
Thank you. Right, some observations from me first of all. The point I made about risks, recording thereof, capturing in the corporate risk register. We know we've got further work to do around that and also on risk more broadly. So I expect you and Molly to ensure that we are on the case in that regard moving forward, please. Second observation from me is we have discussed this operational model at some length on previous occasions now. As I said in what I said at the start, I do think we now need to make a decision about approval or not, and that needs to occur today. And the mood music I would suggest to you is one of approval, but I will come back to it in a moment. Third observation for me is that in terms of the covering paper on page 4 and references the executive team, there's reference there to targeted design work, particularly around digital leadership, partnership and engagement and communications. And in that regard, and I'm conscious they're both with us, I'd like to hear from Dalan and then Helen as to how you feel in terms of recognising the responsibilities that you both need to discharge in terms of this operating model, because I've not heard from you, and content that you, or not, as the case may be, that you're content that you know what's required and that what is required is going to be delivered by you and your team. So Dalan first, please.
Hello. Yeah, so yeah, I mean, I think from my perspective, I do understand what needs to be done. A lot of what I'm doing is going to be enabling and engaging with other people across the organisation in terms of making changes to the various systems that are required to support this. So it'll be more of a coordination than a direct delivery myself. So when we talk about changes to things like the HR systems, accept the hierarchies and the like. But in terms of providing full assurance at this time, I'm still trying to get my head around what's involved in all those changes to be able to do that.
Okay, thanks, Dalan. But you're on the case, essentially.
Yeah. Yes.
Thank you. Helen, thanks, Dalan. Helen? You're on mute, Helen.
Sorry, Diolch, Chairman. Just to say that I've been in post now for 6 months, and a lot of groundwork has taken place, particularly around partnerships and public affairs. In terms of landing the operating model, I think, as Joe alluded to earlier, that lots of conversations have already started taking place behind the scenes, and we are gearing up to deliver the engagement and communications plan as is in the appendices today, and indeed we will be lined up to start that. I imagine not from next week, the week after that, once the Jubilee celebrations have completed. So I'm very confident that we can deliver that, Chairman.
Okay, thanks, Helen. Okay, a couple of more observations from me then. The first on page 7, 2G, is the reference to selection into the vacancies and the anticipation, and I know there can be no guarantee around this, that you, the team, anticipate the majority of the roles will be filled from inside the organisation. That is helpful to note, given our wish, I feel sure, to ensure that where we can, we're providing development opportunities for our staff and providing them with opportunities for progression and development more broadly. Then in terms of the work streams, Sue, that you are overseeing with Jill, it looks like we ought to note the progress that continues to be made around those work streams, but ultimately are going to be crucial to implementation. Right, I then want to take us to, if I may, the recommendations that are listed. The first is, are we happy to approve now the implementation of the revised operating model?
Yes.
Yeah.
Yes. Yes.
Okay. Richard, have you put your hand up for a reason? I'll be a no then. Okay.
Sorry, Mark, I was meant to thumbs up. Sorry, I hit the wrong button.
Okay. Second is to note the commitment of the Chief Executive and Executive Directors to ensure a risk-based approach is taken to implementation. I'm going to make some observations around that in terms of discrete issues that I think we need to address, but are you happy with that commitment as described and to note it? Yes?
Yes.
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 The final point is to note the commitment to the final point of implementation being no later than the 1st of September. Are you happy to note that too?
Yeah.
Yeah? Right. So to Joe and Sue, I think there are a couple of things that would be helpful to agree now alongside what has just been approved and noted. The first is that it will be helpful to receive reports from you at the July and September boards on progress towards implementation. This is a significant change that you are leading, which you and we want to see get right, and the board will need to be kept abreast of progress with implementation and any issues or concerns that are arising. So first thing is, Joe, are you happy to agree that we do that?
Yes.
Okay, and if there is any need to escalate anything outside of the board structure in terms of those meetings, then I'll leave that to you to do so, to both I and the board secretary. Second thing is, Sue, I think it would be really helpful as soon as you are able to provide a recruitment / selection timeline for the posts now that are important in terms of moving the implementation of the model forward, and particularly, of course, the more senior posts. Can you do that when you are ready and sooner rather than later, please?
Yes.
Okay, the third thing is, now I know you've attempted to do this before, but can we attempt it again? It would be helpful for us all to know when people are due to leave the organisation from those posts and what the transition arrangements will be in terms of cover. The last thing I certainly want, I'm sure others don't want it either, is to wander or to visit the organisation